You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for November 17th, 2023. This will be the first AHA recap, including the SELECT trial, ORBITA 2, and ARTESIA trials. A couple of comments before I do the evidence review. First, I want to thank those of you who came up to me at AHA to say you like the podcast. This really means a lot. Thank you. Thank you. Second, every time I get home from a big meeting like AHA, I'm reminded how valuable it is to make the trouble to be there in person. Why? To be with people, to meet people. I think medicine and medical science are people professions. And of course, in Philadelphia, there is that Italian food in South Philly. It's amazing. The third is that I'm not sure how AHA did it exactly, but few medical meetings have garnered this much important medical science. Wow. In fact, on today's podcast, I'm going to include all positive and important studies. Finally, next week, This Week in Cardiology gets a rare week off for Thanksgiving. In the coming weeks this winter, there will be plenty of AHA studies to discuss. Today, I'm going to do the big ones. So first topic is semaglutide and the SELECT trial. The glucagon-like peptide agonist, semaglutide, has been shown previously to reduce outcomes in patients with diabetes. It reduces weight in patients with obesity. The placebo-controlled SELECT trial tested it as a disease-modifying agent in patients with obesity and established atherosclerotic cardiovascular disease. And the drug worked. Clearly, it worked. SELECT, 17,000 patients. The most common qualifying vascular disease was post-MI. The mean age, 62 years old, mostly male. And all patients were already on baseline guideline-directed medical therapy, so any gains from semaglutide are on top of modern medical therapy. The mean BMI in patients was 33. The trial did include patients with overweight as well as obesity. Primary endpoint was a MACE endpoint, cardiovascular death, MI, stroke, and the trial was positive. In the semaglutide arm, 6.5% of patients experienced the first primary outcome event versus 8.0%. This 1.5% absolute risk reduction translated to a 20% relative risk reduction, and this was a highly statistically significant result. Now, there were other notable and positive findings that were induced in the semaglutide group. Patients lost about 8.5% more of their body weight than in the placebo arm. The Kaplan-Meier curves for the primary endpoint began to separate early, and this is well before weight loss took effect, and that certainly suggests other ways that the drug may confer its benefit. Each component of the primary endpoint was lower, including cardiovascular death. Overall death was nearly 1% lower. And these positive findings, like I mentioned, occurred in the setting of already robust baseline care, including statins and antiplatelet agents, in approximately 90% of patients. The drug also reduced the onset of prediabetes by 75%, and also levels of C-reactive protein and systolic blood pressure were lowered. Now, there were adverse events. The adverse events that led to stopping the drug occurred in 16.6% of those taking the semaglutide versus 8.2% on the placebo. So my comments, I don't know how else to feel about this other than it's a positive trial and it's a big change. The degree of relative and absolute risk reductions are similar to statins. Only patients who are overweight and obese also get the benefit of weight loss and likely feel better with semaglutide. So it's a cardiovascular outcome reducing drug that also helps patients feel better and lose weight. Now, since I'm super positive on SELECT, maybe you'd have a counter. Maybe you might say we shouldn't do this indication because it's only one trial. For new indications, we should have 2 trials. And I would normally agree, but I'd also say that it's not like GLP-1 agonists don't have priors on being cardiovascular event reducing drugs. It was the SUSTAIN 6 trial that showed that semaglutide reduced cardiovascular outcomes in patients with diabetes. Plus, I would add that it's quite plausible, right, that inducing nearly a 10% body weight loss is going to improve things like blood pressure, glucose, inflammation, and all of these factors likely lead to lower rates of recurrent MI or strokes. I think that SELECT is going to change practice. For patients with established vascular disease who are overweight or obese, semaglutide is a disease-modifying drug, and we will likely be using it. Now, the other thing that SELECT may change, I hope, is the framing of obesity. Now, since we have a drug that induces weight loss and improves outcomes, the next step in that logic would be that obesity is not healthy. Right now, one of the headwinds of treating obesity is the tension that's created by this cultural sense that all body types are okay. I hope that SELECT and the GLP-1 agonist in general change norms around obesity to make it more thought of as a serious medical condition that requires intervention. Now, another discussion point at AHA was that the Kaplan-Meier curve separated early, and that implicated mechanisms of benefit beyond weight loss. And I think that is right too. Now, I don't know what it is exactly. Maybe it's just simply eating less. But the thing about trials that make them so important is that the why answer is less important. Trials show us whether things work or they do not. And semaglutide sure looks like it works. Now, finally, there is the cost. I don't have the answer here, but we'll have to find a way to get a disease-modifying drug to people in an equitable fashion. And I know health economics isn't simple, but my mind is simple. So Mandrola thinking holds that if we stopped burning money on low-value care, WINC, left atrial appendage occlusion, excess AF ablation, coronary artery calcium screening, we'd have more for proven therapies that are proven in randomized controlled trials. I would say congratulations to the researchers, and get this, to Novo Nordisk, the makers of the drug. I think here is an example where industry and innovation has improved societal health. All right, second topic is ORBITA 2. In 2017, Imperial College investigators nearly killed interventional cardiology with their ORBITA 1 trial. At AHA, they presented ORBITA 2, and interventional cardiology, which was nearly lost, is now found and saved, thank goodness. Before I say anything else about the trial, I want to point out something that I've been thinking about and how special Imperial College must be, right? Daryl Francis, Rasha Alami, they must be much more than incredibly smart scientists. They seem to be really wonderful leaders as well, because the Imperial College team not only puts out unique research, think also the Samson trial with statins, but they also seem like a big happy family when you meet them. Now, another clue on leadership, and I want you to watch for this in future trials. Back in 2017, Daryl Francis had Rasha Alami present and take first authorship of ORBITA. That's nice. In 2023, Rasha Alami had Christopher Rajkumar present ORBITA 2 and take first authorship. As a person who participated in team sports all his life, I really appreciate this sort of leadership. Okay, let's move on. As many of you know, ORBITA 1 really shocked the interventional community when it studied a placebo PCI. We used to call it a sham, but we don't anymore because sham doesn't really fit, against a real PCI. So placebo PCI, real PCI. Now just pause for a second and picture a patient with an angiogram, an angina, and a 90% proximal stenosis somewhere. Imagine the boldness to put a pressure wire across it and leave it unfixed. And in ORBITA 1, when patients with these single vessel lesions were first maximized on antianginal therapy, fixing the lesion made no significant difference on exercise time or angina scores versus the placebo PCI. ORBITA showed that PCI as an add-on in this setting did little more than placebo. But ORBITA 2 was different. It asked and studied a different question. So patients with single or multivessel disease and chronic stable angina were recruited. They then had their anginal medicines stopped 2 weeks before the procedure. Then they went to the cath lab and were randomized to either a real PCI or a placebo procedure. And their blinding procedures were extensive, which is, of course, is critical. Patients and physicians can't know which group patients were in. ORBITA 2 authors also designed an app wherein patients would report daily anginal episodes and a number of anti-anginal drugs. This allowed the investigators to create an ordinal score, which they used for their primary endpoint. They also, of course, measured treadmill time and other angina questionnaires. Now, with this new design, one that isolates the effect of PCI alone, not as an add-on procedure, PCI did work. It worked to improve the angina symptom score. The odds ratio was 2.2 for a better angina score, which was highly positive and significant. Angina frequency was also 3.4 times less often in the PCI arm. PCI also improved the Canadian Cardiovascular Class angina scales. And treadmill walk time was now a statistically significant 59 seconds better than the 16 seconds in ORBITA 1. So a very positive trial for PCI. Now, some may wonder about the ethics of stopping pills 2 weeks before randomization, but I would say that it's totally ethical because recall that in patients with chronic stable angina, angina medicines are not disease modifiers. They're like acetaminophen in arthritis. All patients in ORBITA 2 remained on their guideline-directed medical therapy. The disease-modifying drugs like statins and aspirin were not different in the two groups. So the main interpretation of these two trials is that the current recommendation to start tablets first for angina and then do PCI if symptoms continue may systematically select patients for whom PCI works poorly. Instead, what these trials provocatively suggest is that if angina relief is the goal, patients could rationally choose either tablets or PCI as an initial strategy. Both seem to work. Now, I worry, of course, that in our American sea of overuse, ORBITA 2 will be used to further increase the amount of PCI in stable disease. But if that happens, it's not the fault of PCI or the Imperial College investigators. Now, my perspective on PCI may be a little different than a regular cardiologist. I take care of a ton of patients with atrial fibrillation. So I see patients with AFib, and they are now, if they have a stent, they require both antiplatelets and anticoagulant drugs. Now, I also see stent thrombosis when these drugs are held for bleeding. So if I had chronic stable angina, or the discussions that I'll have with patients, I would likely to try tablets first as to avoid having this metal cage in my coronary that then requires long-term dependence on antiplatelet drugs, and it will always loom as a site of neoatherosclerosis or stent thrombosis. Now finally, I want to remind any new listeners or young people that no matter the degree of coronary stenosis or number of lesions, excluding left main, there is no compelling evidence that PCI reduces heart outcomes over medical therapy. The rate of heart attack or death is the same if you treat stable coronary disease with PCI or tablets. So what we're talking about here is quality of life and symptom relief. PCI for stable coronary disease should be done to relieve symptoms. ORBITA 2 shows that it works well as first-line therapy. ORBITA 1 shows that it works hardly at all when added to maximal medical therapy. I think we're going to see a guideline change so that patients can be offered PCI as first-line therapy. All right, third topic today is a study called ARTESIA. And one of the most common questions in cardiology is what to do when a device, usually a pacemaker or ICD or maybe a loop recorder, finds asymptomatic short-duration AFib, say 1 hour, maybe 2 hours, even 8 hours, 12 hours. Let's say your patient who has this short-duration AFib has a CHA2DS2-VASc score of 4. If this were clinical AFib, that is, this patient came into the office for symptoms and had an ECG that showed AFib, you would definitely recommend oral anticoagulation therapy. You do that because there are oodles of trials showing that warfarin was better than placebo or aspirin, and then subsequently DOACs were similar to or better than warfarin. But so-called subclinical AF is different. It's shorter in duration, and it's only discovered because of technology. We don't even know if it is an actual disease or perhaps just a condition of aging. The thing is that subclinical AFib looks like AFib. When you look at the device, the atrial channel shows fibrillatory activity. The V channel has an irregular rhythm when there is an intact AV node. But the duration of these electrical episodes are shorter and patients rarely feel them. Now, at the ESC meeting a couple months ago, the NOAA AFNet-6 trial, NOAA trial for short, of Apixaban versus placebo for patients who had subclinical AF found pretty surprising results. The DOAC drug, Apixaban, did not significantly reduce the primary endpoint of stroke, systemic embolism, or CV death, but it did increase the rate of major bleeding by a statistically significant 31%. NOAA, therefore, was stopped prematurely for both perceived futility of efficacy and harm from bleeding. Now, the explanation for NOAA was that subclinical AF conferred a very low stroke rate of approximately 1% per year. Now, I know sometimes my eyes glaze over when we're talking about yearly stroke rates. What does that mean, 1% per year? But I think this is an important concept, and we use it really every day with the CHA2DS2-VASc score when we treat clinical AFib. The idea is simple. Oral anticoagulation is not free. It does reduce stroke, but it also increases bleeding. If the CHA2DS2-VASc score is high enough, then we use oral anticoagulation because higher CHA2DS2-VASc means a higher yearly stroke rate. For instance, we estimate, emphasis here on estimate, that a CHA2DS2-VASc score of 2 means a 2.2% yearly stroke rate. And at that level or higher levels, we feel that the absolute risk decrease of stroke from oral anticoagulation is outweighed by the absolute bleeding rate increase. And that leads to what we call a net benefit. Well, if the yearly stroke risk is low, then the absolute risk decrease with oral anticoagulants will not outweigh the bleeding rate increase. And that is kind of what happened in NOAA. But ARTESIA was a different type of trial, right? Here, this is Apixaban versus aspirin. It enrolled more patients, 4,000 instead of 2,500. ARTESIA followed patients for longer, and they had a more focused endpoint of only stroke and systemic embolism. It's more focused than NOAA because NOAA had stroke, systemic embolism, and CV death. So ARTESIA was set up to have more stroke events. Now, ARTESIA used aspirin in the control arm, which would also mitigate the delta in bleeding events, right? Because we know in Avero's trial, aspirin and Apixaban had very similar bleeding rates. So now let's go into the details of ARTESIA. The average age of patients was pretty old at 77 years. Slightly more than a third of patients were female. The mean CHA2DS2-VASc score was 3.9. The median duration of AFib, however, was only 1.5 hours, and only 20% of patients had AF duration longer than 6 hours. The results, primary endpoint, occurred in 55 of 2,015 patients in the Apixaban arm versus 86 of 1,997 patients in the aspirin arm. The percentages are really small, 0.78% versus 1.24% per patient year. The difference of only 31 stroke events in a trial of more than 4,000 patients yielded, however, a statistically significant relative risk reduction of 37%. So the hazard ratio 0.63 with very tight confidence intervals and a highly significant p-value. The authors assessed and stressed stroke severity, and they reported that 18 of 55 strokes in the Apixaban arm were disabling or fatal versus 36 of 84 strokes in the aspirin arm. So that's 33% versus 43% respectively. The relative risk reduction for these severe strokes that had a modified Rankin scale of 3 to 6 was a little bit higher at 49%. So 37% reduction of stroke and systemic embolism overall, but a 49% reduction of really bad strokes. The safety endpoint of major bleeding occurred in 86 of 1,989 patients. That's 4.3% of patients in the Apixaban arm versus 47 of 1,972 patients. That's 2.3% of patients in the aspirin arm. And this is an excess of 39 major bleeding events. That relative risk increase was 80%, hazard ratio 1.80 with really tight confidence intervals and a highly significant p-value. Now, the authors also stressed and subdivided the bleeding events, noting that most bleeding events were handled with supportive care. Fatal bleeding and intracranial bleeding events were actually numerically lower in the Apixaban arm, but essentially no different. So these significant reductions in stroke and bleeding increase led the authors to make two types of conclusions. The basic conclusion, the one that reads in the abstract of the New England paper, reads, quote, among patients with subclinical AF, Apixaban resulted in a lower risk of stroke or systemic embolism than aspirin, but a higher risk of major bleeding, period. That's it. But at the meeting, and in the final conclusions in the manuscript, the authors ask us to consider that A, strokes are worse than bleeds, B, Apixaban reduced all strokes, but also disabling strokes, C, most bleeding events could be managed without disability, and D, the worst bleeds like intracranial hemorrhage or fatal bleeding were not increased in the Apixaban arm, and this led them to a couple comments. One is, quote, simply counting strokes as compared with bleeding events might suggest a neutral overall effect. They write, noting that, quote, strokes involve permanent loss of brain tissue, whereas major bleeding is usually reversible with most patients having a complete recovery. So they're making a distinction that strokes are worse. And then second comment they make in the manuscript, in this trial involving patients with risk factors for stroke who had subclinical AF, Apixaban resulted in a lower risk of stroke or systemic embolism than aspirin. This effect included a substantial between-group difference in disabling or fatal stroke. And then the risk of major bleeding was higher with Apixaban than with aspirin, but most bleeding cases responded readily to supportive care. Now, I wrote an opinion column about this, and I differed a bit from this preference for anticoagulation. I totally understand and get the fact that the net benefit leans that way. It does. But, of course, human beings aren't robots looking at risks and benefits in pure mathematical terms. The absolute risk reduction in stroke and bleeding was really small. The risk reduction over 3.5 years was about 1.6%, so that's an NNT of 67. The risk increase was about 2%, or number needed to harm of 50. So I think it's a really tough call. What I wrote is that when you present this to patients, different people will feel differently about it. Some patients are more fearful of stroke and they would want to have the oral anticoagulant. Patients more fearful of bleeding might hold off. Keep in mind, too, that it's not just the calculus of stroke and bleeding. Patients also have to factor in the burden of taking a twice-daily pill and accepting its pretty high cost. The thing is that this data, both trials combined, doesn't allow an algorithm or quality measure. There will be no correct answers, and I kind of like that. You have to talk with your patients and assess their goals of care and preferences. Now, one thing to look forward here is a patient-level meta-analysis. Dr. Bill McIntyre and colleagues, including authors of both trials, have published a trial-level meta-analysis. Circulation published a study. I'll link to it, and it shows that the NOAA and ARTESIA studies are entirely consistent. But what we really need, I think, is a patient-level meta-analysis where they can graph the duration of subclinical AF with the treatment effect. And I suspect that that graph will show that a treatment effect of oral anticoagulation will look better, reach more net benefit with the longer duration AF episodes. Now, I don't know that for sure, but I think that. And I think that because that in the TRENDS observational study, it took about 5.5 hours to see an elevated stroke risk from subclinical AF. And in the ASSERT observational study, it took even 24 hours to see elevated stroke risk. So we'll see and we'll learn more from the coming studies. Okay, I've gone on for a good while, and I've only talked about 3 studies, but these are 3 really major studies in cardiology. In the coming weeks, not Thanksgiving, we'll take next Thanksgiving off, but in the coming weeks, I'll review the many other papers from AHA, and there's certainly a lot to keep us going for many weeks. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, take the time, give this podcast a rating at whatever app you use. Write us a 1 or 2 sentence review. These things go a long way to helping others find us. Until 2 weeks post-Thanksgiving, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.